So I hope you enjoyed the class last week, and I'm sure you miss me by now. I'm happy to be back.
No.
You don't miss me?
No. I miss you very much. This is assignment.
Okay, you will get an assignment. The more you ask, the more you get.
No. And I would like to ask for the
Each
extension.
time you ask me about the assignment, there's one more question. So, okay, I'll make the assignment ready in the next few days, I hope. So let me go back to the topic that we started last time, the optimal contracts. So let me remind you a little bit what we did last time, and then we continue. As I said, this is one of the most important topics in health economics, and also in health policy. If you look at what people talk about a lot in healthcare, it's policy makers, managers, decision makers, and also in academia, then the issue of optimal contracts and payment mechanisms is one of the most important topics. In fact, it's not only in health economics, it's in economics altogether. I mean, if you ask me what I think the most important questions that economists ask is exactly the same question of how to design contracts. So if you want more generally, how to design incentive schemes to induce people to behave according to your objectives. In fact, I think that's what economics is all about. If I go and I ask someone, tell me what your objective is, if you are a prime minister, or if you are a mayor, or if you are a manager, or whatever, and then these people choose their objectives. It's up to them what their objectives should be. The only thing, or the one thing that economists can do is say, well, given your objectives, whatever they are, let me help you think about incentive schemes. So if you want contracts, it will help you achieve these objectives. And usually, these kind of contracts are not very simple and are quite involved. So the way I think about contracts, and this is what I started talking about last time we talked, was that actually every contract, almost any contract that you look at, and it doesn't matter whether it's an employment contract or insurance contract, or if you rent an apartment or you rent a car, or a marriage contract, whatever. I mean, these four elements enter and will be important. And when we talk about the optimal contract, we usually think about the right balance between these things. So one element that we always think about when we think about contracts is incentives. Every contract creates some kind of incentives. It affects the behavior of the people that are involved, and sometimes also the behavior of the people that are not part of the contract. Okay? And usually the idea of a good contract is a contract that gives you the incentives, or gives the people the incentives to do the things according to the objectives of the person or the group or the organization that designed the contract. So if I am an employer and you are an employee and I give you an employment contract, then the question is whether the contract gives you the incentives to do what I want you to do as my employee. But we have to remember that once I give you a contract as my employee, it's not going to affect only your behavior. It may affect the behavior of the other people that work with you. It may affect the people outside the organization, and it may affect my behavior as well. So whenever we look at the contract, we have to see who is affected by these in terms of the incentives and how are they going to behave. And in fact, if you go back to what we talked about at the beginning of this module, when we talked about health insurance and moral hazard, this was another example of incentives, because what I showed you then is that if people have insurance, if they have health insurance, they tend to consume more because they don't pay for the services, than what they would have consumed had they not have an insurance. So when people buy health insurance, we know that it's going to create incentives for these people to consume more than if they didn't have insurance, because they don't pay. They pay the premium, but they don't pay for the service. But we also have to remember that the same contract may affect not only the behavior of the patients, it may affect the behavior of the doctor. If the doctor knows that you have insurance, he may decide or behave differently in terms of what to prescribe and how to refer you or whom to refer you to. He may behave very differently than if you don't have insurance. And it's true about your family as well, and maybe other things. So incentives are always very important, and we'll see some examples in a minute. However, this is not the only thing that is affected by a contract. The other thing is risk sharing. And any contract involves some kind of risk by different elements that are part of the insurance or the contract. And some contracts actually may be very good in terms of incentives, but they induce or they create very wrong risk sharing. And in fact, if you go back to the example I worked on last time, if you remember last time, we looked at this formal analysis of a case where you have a worker and the manager gives the worker a contract, and the worker needs to decide whether he works hard or he doesn't work hard, whether he exerts a lot of effort or very little effort. And we saw then that in some sense the best contract would be that you tell the worker, look, if you succeed, I'll pay you a lot. If the outcome is high, in this example that we did last time, I'll pay you a lot. If the outcome is low, then I'll pay you very little. This is the right contract in terms of incentives. Just to pay the worker according to the outcome, which gives the worker a very strong incentives to put a lot of effort. The problem with this kind of contract was that it's very risky for the worker, because he may work very hard, he may put a lot of effort, but for some reason, exogenous reason, the outcome may be low, or the profit may be low. So if the outcome is not is not directly affected by the effort, and there is some other things going on, it can be the case that the worker will put a lot of effort, but the outcome will be bad. If you think about, for example, healthcare, it can be the case that the doctor will do the best job he can with the patient, but the treatment will fail because there are other things going on. You may be the best doctor trying to save the patients, but sometimes it doesn't work. So good contracts in terms of incentives may be very problematic in terms of risk sharing. And again, we'll see some examples soon. The other thing that is very important when you look at contracts is whether it's basically how much you can monitor what you are supposed to monitor according to the contract. So, and we also saw this last time when we looked at this formal analysis that we did 2 weeks ago with the example. For example, the agents or the employees' effort is sometimes not, sometimes you can monitor it, sometimes you cannot. And if you remember, actually here I also talked about the distinction between what we call things that are observable and things that are verifiable. When you write a contract and you tell the worker, look, I will pay you only if you work hard, and I will not pay you if you don't work hard, in many cases, this is, whether or not you work hard is observable by the boss, by the manager, but it's not verifiable in terms of going to court or convincing the judge. So I can, write a contract that says, look, I will pay you a lot if you work hard. At the end of the month, I tell you, look, you didn't work hard, I don't want to pay you. You will say, I did work hard, you should pay me. And we go to court and the judge say, I don't know, I wasn't there. I don't know if you worked hard or not. I cannot do anything about it. So that's a case where the effort of the employee may be observable by the boss, by the manager, but it's not verifiable. So we make distinction between 3 cases. One case where things are observable. Maybe the best case in terms of contracts is that some things are verifiable. For example, whether or not you show up to work in the morning, it's verifiable. I can prove to the judge that you didn't come to work today. So that's verifiable. Some things are not verifiable but observable. Namely, I can see whether you worked hard, but the judge not. So that's observable but not verifiable. These are things that cannot be part of a contract because there's no way to verify it. Okay? And there are things that are not observable and not verifiable. For example, if you're supposed to practice before the exam or to study at home before the exam, I don't know. So in some cases, in some cases, whether or not you did what you were supposed to do is not observable, not verifiable, and there are many, many, many interesting and important examples of this. Okay? So we have to remember that contracts can only contain things that are verifiable. In reality, often there are what we call informal contracts, which is not what I'm going to talk about so much today. Informal contracts are contracts where you and I kind of understand what each of us is supposed to do, but it's not written in the contract, and if you don't do what you're supposed to do, or I don't do what I'm supposed to do, then maybe next week we just we don't continue working together, we don't collaborate anymore, but it's not a formal contract that we need to go to the judge to decide whether or not we did it. So if you think about, for example, I don't know how many of you are, but marriage has a lot of informal contracts between the couple. But it's not only marriage, there are many, many other cases where there is informal contract. We understand what each of us is supposed to do, and we can observe whether we do it or not, and we actually may act on it if you don't do what you're supposed to do, but it's not part of a formal contract. Okay? So that's what we mean by monitoring. Things that you can observe or you cannot observe, or you can verify or you cannot verify. I don't know how many of you have had this experience, but let me give you one example. If you travel to the United States and you take a taxi, okay, then you will find out something very interesting. If you take a taxi outside New York, not in New York, when you just get on the taxi, the driver will ask you, where do you want to go? You tell him, I want to go somewhere, in Los Angeles, let's say. So he takes the address, he turns on the meter, and then at the end of basically when you get there, he just shows you how much you have to pay, and you pay. If you go to New York and you ask the you tell the driver where you want to go, he will always offer you a price, almost always, without trying not to turn on the meter. Actually, you say, how about if I charge you $20? And you may say yes, no, whatever. It's actually almost only in New York that the driver will basically try not to turn on the meter and just offer you a price. Now, why do they do it? Why is it different in New York than other cities, let's say? Any idea? It has to do with monitoring. Any guess? You are never in New York, or you're never taxi drivers, or neither of them. Okay, so the reason is this. In New York, the taxi driver has, only in New York, taxi drivers, the taxi driver is not the owner of the taxi. He just drives it, but there is someone else who owns the taxi. It's called a medallion. You own the right to have a taxi. So the owner of the taxi gives the taxi to the driver, and there is a contract between them. It's a contract between the owner, the medallion, and the driver. Now, in all cities, other than New York, the contract is such that the driver rents the taxi for a week, pays a fixed price to the owner, let's say $200, $1,000. So the contract between the driver and the owner of the taxi is very simple. The taxi driver rents the taxi for, let's say, a fixed price, and then it's his for the week. So he has no problem turning on the meter and just charge the passenger a price, because the owner doesn't care. The owner gets his fixed price. In New York, it's different. In New York, the contract between the driver and the owner is that the driver has to pay the owner a fixed share of the meter. of the revenue. Well, then what do you want to do if you're a driver? You don't want to turn on the meter because then it means that you pay more to the owner. So you try to avoid turning on the meter. This is an issue of monitoring. In other cities, there's no problem of monitoring. I don't care how much you drive. I don't care how much you charge. You give me the price, and it's very easy to monitor. At the end of the week or the beginning of the week, give me the rent and take the taxi. So there's nothing to monitor. Okay? In the other cities, in New York, I'm sorry, I need to monitor how much you drive because I need to know how much you have to pay me. And therefore, drivers try to avoid paying and they try to avoid turning on the meter. However, there is another interesting thing if you think about this contract. What does the contract tell us about risk sharing? Which one is better in terms of risk sharing? Whether in New York or the other cities, which one is better?
Other cities.
Obviously, in other cities, it's very bad. Why? Because all the risk falls on the driver. The owner gets a fixed price. Now, if it's a good week, the driver gets a lot of money. If it's a bad week, he doesn't get a lot of money because he doesn't drive much for some reason, but he has to pay. So in terms of risk sharing, actually, other cities is very bad. All the risk falls on the driver. In New York, what they do is actually risk sharing. Because I pay you more if I drive more. I pay you less if I have less. My revenue is smaller. So you can see how the risk sharing enters in both cases. In one case it's safe, in the other one, one case it's basically they do risk sharing, in the other one they don't. All the risk falls on the driver. So you can see, even this very simple situation, you can think about risk sharing, you can think about monitoring. You can also ask yourself how the incentives change between these two contracts, between the driver and the owner. The incentives are very different. For example, in New York, the drivers have less incentives to drive a lot. Because whatever they do, they have to pay a share of it to the owner. In the other cities, the more I drive, the more money comes to my pocket because I already committed to pay you a fixed rent. So you can see how these things may be different. And we'll talk about it in the context of healthcare in a second. Then there is a screening question. When you offer a contract, let's see who is attracted by this contract and who is not. If I offer you a contract to pay you according to something, some people may like it and may take the contract. Other people may say, well, I don't like this kind of contracts. I have better alternatives. And you have to think about it when you design a contract, whether it's going to attract the right people from your perspective. Sometimes it does, sometimes it's not. If you think about the example of the taxi drivers, maybe these different contracts in New York and the other cities affect or attract different types of drivers. So you have to think about it as well. Now, every contract, if you ask me as an economist, if you ask me what do you think about this contract, I will look at it and I will design, I will analyze the incentives, the risk sharing, the monitoring, the screening, and then I will say, well, maybe we can improve, maybe we cannot improve. Now, the fact is that it's never the case that you have a contract that does the best in all of them. There is always a trade-off. The best contract in terms of incentives may be not so good in terms of risk sharing, and if it's good maybe for risk sharing, monitoring may be very problematic. As I showed you in the example 2 weeks ago, if you can monitor effort, if effort can be monitored, then I can give you an excellent contract without any risk and without the best incentives. But only if you can monitor effort. If you cannot monitor effort, then there is a trade-off between these two things, with incentives and risk sharing, and I encourage you to go back to this example that we did last time. Because we will have an example like this in the exam. Now I gave you the incentives to go back. Okay. So now, here are some general observations about healthcare and contracts. This part is going to be very informal, but still it's actually very important. The first observation is that the less verifiable the agent's actions are, the harder it is to design an optimal contract. Now again, let me just remind you the language. Agents, I mean the people that are involved in the contract. So the best way to think about it, again, go back to the example from 2 weeks ago, there is a manager and an agent. And the agent is supposed to do some work for the manager. For example, you work for me, or if, for example, I'm the hospital, I'm the manager, and you are the doctor that works in the hospital. Or if you want, I am the patient, and you are the doctor that is going to treat me. So you are my agent, because you are going to do something for me as the patient. And many other examples. So, and the hospital can be thought of as an agent of the HMO or whatever. So I'm the HMO, I insure the patient, and the patient needs to be hospitalized. So the HMO is the manager, and the hospital is the agent that's supposed to do something for my patient as the agent. Now, that's something we already talked about last time, and I mentioned it a few minutes ago. The less verifiable the agent's actions are, the harder it is to design an optimal contract. Because if everything you're supposed to do for me is verifiable, that's easy. I'll just put it in the contract. I tell you, look, you did this. If you don't do it, I don't pay you, or I pay you less. That's easy. But the problem becomes, or things become much harder when you're supposed to do things for me, and I can only monitor them indirectly. For example, you're supposed to exert effort, but I cannot monitor your effort. The only thing I can do is monitor the outcome of the effort. Whether or not you work hard, I may observe, but I cannot put it in the contract. So now the question is how the outcome is related to the effort. Sometimes it's very much related. Sometimes there is so much noise around that even if you put a lot of effort, the outcome may be bad. So if things are verifiable or close to verifiable, it's easier to get the best contract you want. But in many cases, it's not. And in fact, in healthcare, many actions that healthcare providers are required to take are not verifiable. Some of them are not even observable. So if you think about a doctor that treats a patient is supposed to do a lot of things that cannot be put in a contract. You cannot tell the doctor, if you don't do it, I don't pay you. The doctor has to listen to the patient, has to do the right examinations, which may be very different from one patient to the other. It's not that all patients are the same. Everyone has its own story, its own, basically, other diseases, other treatments, and so on. So in healthcare, it's one of the cases where many things that the doctor is supposed to do are not verifiable. You cannot put it in a contract. And I want you to remember it, because that's probably one of the most important issues in healthcare. Many things are not verifiable. If you remember, I gave you this slide, or if I don't, I can tell you now. Let me give you one simple example. The patient comes to the doctor with a chest pain. He has pain in his chest. There are 7,000 different treatments for this particular case. There are 7,000 different clinical guidelines of what you're supposed to do with one case, chest pain. Chest pain can be a result of many different things. Many different things. So just chest pain, there are 7,000 things that you can do, different things. You cannot monitor whether the doctor did the right one from these 7,000 ones. It's just impossible. So that's why contracts in healthcare are extremely difficult. That's one thing. The other observation, the less standard the service is, the harder it is to design and optimize. What does it mean? If the agent is supposed to do something very standard, suppose you work in a pizza restaurant and the only thing the agent has to do is to do the pizza. So that's quite standard. He has to do 1, 2, 3, 4 pizzas, which are more or less the same. Suppose it's one type of pizza, because there are different types of pizza, it's not standard maybe. In healthcare, that's not the case, because I told you, each patient is different. So you cannot say, well, all patients are the same, everyone that comes with a chest pain, there is one standard procedure, let's do it to all of them. It's hardly ever the case that you have examples like this in healthcare. Any medical problem is not standard because it's different from one patient to the other. Given that it is different, contracts are very difficult to design. You know, if you think about a worker that's supposed to do just one thing, then you tell him, the more you do of this one thing, the more I pay you. The less you do, the less I pay you. Because it's one thing you're supposed to do. You're supposed to do one thing, and you do 1, 2, 3. Each time you do it, I'll pay you more. In healthcare, you cannot do something like this because it's supposed to do very different things for the different patients. So then contracts are very difficult, and that's exactly the other case. You know, I can give you actually, there is a very interesting article about it. There is someone in the United States, a very well-known doctor. His name is Atul Gawande. I recommend you remember the name, Atul Gawande. He was born in India, he moved to the United States, he became a very well-known surgeon in Harvard. Do you know him? Or you just laugh? Because the name is funny? Is it? Okay. So anyway, he has written several interesting books about healthcare. One book is called Complication. He recently wrote another book about the end of life, how you should treat patients at the end of life. He tells about his own personal story about his father and so on. He's really a very, very smart, well-known guy. He appears on TV a lot in the United States. And he also writes articles in the New Yorker, which is, some people read it, which is good. Actually, one of his articles from the New Yorker was something that President Obama, when he was elected to be the president, he made many copies of this particular article from the New Yorker and gave it to all his staff in the White House to say, here you can read what's going on in the US healthcare system. But in any case, Atul Gawande has a paper also in the New Yorker that is called the Cheesecake Factory. The Cheesecake Factory. And it's very much related to this particular observation that I have. Now, what's the story about the Cheesecake Factory? I don't know how many of you know, but the Cheesecake Factory is what? I mean, some people have been to the US. Cheesecake Factory is it's a restaurant, it's a chain. It's a restaurant chain. Almost every big city in the United States has a Cheesecake Factory restaurant. Now, if you go to this restaurant, it's a very interesting restaurant. It's huge, usually very big, usually very crowded. And when you ask for the menu, they give you a book like this with the menu. And they have everything. They have pizzas, they have Indian food, they have Thai food, they have Japanese food, they have American food, everything. Now, usually these kind of restaurants are terrible, right? If they serve everything, if they sell everything, how can you be good? And in fact, it's not only this, and you have a picture of everything. So it's a huge menu. So he went with his family to this restaurant, and he expected to get a very bad food. And it turns out to be great, actually. Everything was excellent. And his kids, one of them asked for Indian, the other one Italian, I don't know. And they all loved it, and he loved it. So he said, how come they do everything so well? So then he went to the kitchen, and they, of course, took him and they showed him. It's all in this article. You can read the Cheesecake Factory and you'll find it. And, well, he found out two interesting things about this restaurant. And that's why the food is so good. The first thing he found out is that when a person orders a dish, or whatever you order, the cook who's supposed to do this particular dish for you, whether it's a pizza or whatever, he has a screen, and the screen tells him exactly what to put. He doesn't do anything by himself. You should put 2 spoons of sugar, one whatever package of margarine, or whatever. It's basically, the cook, in a sense, works like a machine, like a robot. He doesn't do anything by himself. That's the first part. So that's a very standard thing. And for every dish, that's what they do. And there is another part, which is even more interesting. Every dish, before it goes out from the kitchen to the customer, there is a supervisor. And the supervisor looks at the dish, every dish, and gives it a mark between 1 to 10. Everything which is between 1 and 7 goes back to the garbage. Goes to the garbage, and they do a new one. And they call the cook to explain why he was wrong. 8 and 9 go out, but they still call the cook to explain why he was wrong. 10 goes out like this. Okay, that's the problem. So then Gawande asked himself in this article, why can't healthcare be like this? Why can't we have these two things? One, a patient comes to the doctor with a medical problem. There is a list exactly what he's supposed to do. And then someone else checks whether he did what he was supposed to do. Now, obviously, you can see why this is very difficult to do in healthcare, because even if you have two patients with the same problem, it's like two customers ordering the same pizza, the treatment may be very, very, very different, because you have a different background, or you have other diseases, or you take other medications, or you're many reasons. So it cannot be like this. And basically also, so the first part of the analysis is not so relevant to healthcare, because you cannot just give the doctor a clear instructions, even though I should say that in healthcare we have now what we call clinical guidelines, which in a sense are like this story about the cook, but this is only for standard cases you can do it. And then obviously you cannot have someone that will check everything that the doctor does and give him a mark between 1 and 10. That's not going to work. So you can see the difference between these two. And again, I encourage you to read his article, which is very nice. It's called The Cheesecake Factory by Atul Gawande. And if you're interested in healthcare, you can also go to his website and find some of his new books, which are extremely well written. It's not for doctors, it's for people like us. Okay, so that's it. Another observation, the more agents are involved in providing a service, the harder it is to design the optimal contract. Again, if you have just one agent who is supposed to do something for you, it's easy, or it's easier. But if you have a job and several people are supposed to coordinate in order to perform this job, then it's much harder in a sense to design the contract, because not only that you have to give each of them the incentives to work hard, you have to give them the incentives to work together and to coordinate. And if the outcome is bad, you don't know whom to blame. It's not like in a one agent case, you know, if the outcome is bad, maybe you didn't do your effort or what you're supposed to. When it's a multiple agents problem, then you have to think about the coordination, and it's not so easy. Everyone will say, I did what I was supposed to do. And in fact, it may look to you very abstract. One of the most interesting things that's going on in healthcare today, and I will talk about it soon, is what we call bundled payment. And bundled payment means that you don't pay each doctor separately, you pay a group of doctors for doing the bundle together of treating a patient. And I'll come back to this later on when we talk about payment schemes in healthcare. So that's another example. And again, what I mean in efficient treatment often means the involvement of several agents in healthcare. Okay? A patient comes to the hospital, unfortunately, with cancer. Usually the treatment of cancer involves many different providers. Doctors, nurses, social workers, different experts in healthcare. It's not one doctor. Now the system used to be that every doctor who treats this patient is paid for what he is supposed to do, or for what he does. Today we move to another way of saying, no, I don't look at only what you did, or what he did, or what she did. I want to look how you coordinated, or how you integrated the treatment, and I'll pay you according to this. But that's harder, much harder than each patient, or each agent, doing, each doctor does what he does by himself. Another important thing about optimal contracts is the following observation. The more tasks an agent is asked to perform, the harder it is to design an optimal contract. This is, according to some people will say that when you talk about contracts, not only in healthcare, but contracts in general, this is what is called in economics the multitasking problem. Now, why is this a problem? The problem comes from the fact that suppose you have an agent that's supposed to do several things as part of his job. So you hire a worker or a doctor or whatever, and his job is to do different things. Now, why is this a problem sometimes? Because suppose that some of the things that he can do are verifiable. You can verify whether or not he does them. Other things he's supposed to do are much harder to monitor. Let me give you an example. You have a teacher. And you think about the teacher, not for high school, but maybe as a young kids, first grade or kindergarten. Now, if you think about this teacher is supposed to do very different things with the kids. One is to teach them so that they will be able to read and write and pass the exam. This is something that is easily verifiable. You can see whether at the end of the year, how many of the kids in first grade can read and can write and maybe can do some calculations. So these are the things that the teacher is supposed to do, which are relatively easy to verify. But there are other things the teacher is supposed to do which are not less important. They should teach the kids to become more curious, to become critical of things. There are many to become more creative, to become more, there are many things, especially for kindergarten or young children. The teacher is not only supposed to teach them to do things like read, write, and whatever, mathematics. There are many other things you want the teacher to do with young children. But these other things that the teacher is supposed to do are extremely difficult to monitor and to verify. Okay? Now, if you tell the teacher, look, whatever I cannot monitor, I don't monitor, but at least I'll monitor what I can, namely whether the kids can read and write, and I'll pay you according to this. Why is this a problem? Why is it a problem? You say, well, whatever is not verifiable, I'm not going to verify, but at least let me verify what I can verify. Why is this a problem? I mean, the problem is that if this is what you do, the teacher will focus on the things that you measure. And he will not do what he's supposed to do and you don't measure, because you don't measure him. And this is what we call the multitasking problem. And it's almost always the case that employees, doctors, teachers, agents are supposed to do different things. Some of them are easy to verify, some of them are difficult to verify. If you offer a contract that focuses on the things that you can verify, you may get very good performance in the things that you verify, but you may actually find out that the doctors don't do, or the patients don't, or the employees or whatever, don't do the other things which are not less important. Okay? Now in healthcare, that's exactly the case. In healthcare, a typical provider is required to do many different things, take a family doctor. Family doctor is supposed to do many different things with the patients, depends on the case. Some of the things that the family doctor does, we can easily verify. For example, if he referred the patient to some tests, that's something you can verify. But the other thing that he's supposed to do, which you cannot verify, for example, was he supposed to send him to this test altogether? I know if he sent him to the test, but maybe he shouldn't. Maybe you don't need this test at all. That's much harder to verify. Now, one of the biggest problems in healthcare, and I'll come back to this when we talk about quality measures. Our next class, I will talk about quality measures in healthcare, and you'll see that this is one of the biggest problems in healthcare, the multitasking problem. Okay? So I want you just to see how complicated it is to design a contract. And let's look at an example to see how all these things enter into our calculation. Suppose you have a doctor, okay? And now you ask yourself, how should we pay this doctor? You are, let's say, suppose you are a hospital, or maybe you are an HMO, and there is a doctor working for you. Now you can offer him payments in different ways. One thing you can do is pay him a fixed wage. The other thing is what we call fee for service, pay for procedures. Namely, for each different procedure that the doctor does, you pay him some payment. Okay? This is what we call fee for service. This is probably the most common method of reimbursing doctors. That's usually how doctors are paid. Sometimes doctors are paid a fixed wage, the end of the month, they get a salary, whatever. But in many cases, in reality, in the world, they pay for different procedures, different things. So if you do an operation, we pay you for the operation. If you do other things, we pay you for other things. Okay? That's what we call pay for procedures. Another thing which has become more popular recently is what we call P4P, namely pay for outcomes, or pay for performance. Namely, we don't look at what you did. We don't look at the procedure, we look at the outcome. Did the patient survive? Did the patient recover? Does the patient feel better? Has his blood pressure gone down because of your treatment? Have the diabetes or whatever, all these other things that we can measure. So we need to measure the performance and see whether indeed you perform, the outcomes are better. The better the better are the outcomes, the more I pay you. This is what is now becoming much more common. And as I'll talk about it again, when we talk about quality measures, because remember, in order to pay on outcomes, you have to measure outcomes. I'll talk about these things separately. We'll see that this is a very problematic way of paying doctors. Actually, the incentives are not always the right incentives here. We'll come back to these ones. So that's another way. Pay for following the guidelines, it's almost like pay for outcomes, but not exactly. Here, I basically see whether you are, as I told you, many medical problems, not all of them, have what we call clinical guidelines. They say, if a patient comes to you with this particular problem, here is what you're supposed to do. This is what we call clinical guidelines. Now, not all medical problems have clinical guidelines. In fact, many of them don't, but some of them do. So then the question is, I'm going to see whether you follow the guideline. If you did, I'll pay you. If you didn't do, I'll pay you less, or I won't pay you. That's also kind of quality measure, if you want. There is pay for diagnosis. In this case, it's not very common, but I just want to mention it because I'll talk about it later when we talk about hospitals. In the case of hospitals, this is a very common way of paying hospitals. I'll come back to this later. Namely, here, I don't pay to the doctor according to the procedure he did, what kind of treatment he gave. I don't pay according to the outcome. I just pay according to the medical problem that the patient has. So a patient comes to the doctor does a diagnosis, and the doctor says, this patient has diabetes. Well, if you have a patient with diabetes, I'll pay you differently than if you have a patient with something else. So you pay according to the diagnosis, to the medical problem. That's not very common way of paying doctors. And then there is obviously pay for patients, namely, sometimes we call it capitation, per capita. Namely, I want to see how many patients you see. I don't care what you did in this case. I want to see how many patients you see, and I pay you according to the number of patients. Now here there are different ways of doing it, actually. One way of paying for patients, the simplest way, is each time a patient comes to you, I pay you a fixed price for the patient, regardless of what you did, regardless of the outcome. In a sense, this is like a pay for visits. Each time the patient visits the doctor is paid. Another way of doing it, which is actually common, for example, in the UK, is that each doctor has a list of patients which belong to this doctor. That's the doctor's list. Okay, and that's what we have in the US. Now, the more patients you have in your list, the more I pay you, regardless of whether they come to you, regardless of how many times you see them, regardless of the procedures, regardless of the outcomes. I just look at your list, and if you have more patients, I pay you more. If you have less patients, I pay you less. Now, usually this kind of thing is you don't pay the same for each patient. For example, if you have an older patient, I pay you more. If you have a sicker patient, I pay you more. Sometimes I pay you differently for men and women, because in certain ages, women go more to the doctor, in other ages, men go more to the doctor. So when I say per patient, it's not really one patient or one price for everyone. And this is what we call the capitation formula sometimes. The capitation formula says how much I pay you for each patient as a function of his age, gender, medical history, whatever. But the only thing which is interesting here is that I don't really care in this payment method about what you do with them, only about how many of them you have. Okay, that's what we call capitation or pay for patients. And the other thing which is sometimes you have, which is kind of related to this, is that you give the doctor a budget, say this is your budget to treat your patients, and then the more you spend on the first patient, the less you'll have for the second patient, and so on. Okay. Now, basically, just 2 points to say about this before we take a break. First of all, in terms of the optimal contract, then you can ask yourself, okay, so which one is better? Which one should we use? And if you think about it for a second, and we'll do it after the break for a second, you will see that one way to compare between these given contracts or these contracts is exactly according to what I started this class with. Let's see what kind of incentives this one creates, what kind of incentives this one creates, and so on. So one dimension to compare which one is better, if you want, is to look at the incentives. The other thing to compare is risk sharing, which one creates better risk or risk sharing. The other thing is monitoring, which one is easier to monitor. You can see that the fixed wage is in some sense the easiest to monitor. You don't have to monitor anything. You pay the doctor a fixed wage. So there's nothing to monitor. Fee for service, you need to monitor the services that the doctor provided in order to pay him according to this. So it's much harder to monitor. But they create also very different incentives. Okay? So you can see that you can analyze each of them according to the incentives, according to the risk sharing, according to the monitoring, and according to the screening. What kind of doctors like to join you if you offer this one, and who are the doctors that will actually join and will work for you if you offer this one. And if you think about it for a second, you will see that some of these contracts are better in terms of monitoring, the other are better in terms of risk sharing, and so on. So let's take a break, and then we'll come back and talk about this and some other things.